Right, so today's lecture topic is neuroradiologic anatomy, and today's class will cover mostly anatomy of the spine and particularly limited to the craniovertebral junction and the cervical spine. So this overall is going to be a little bit of a longer seminar series, and I'm hoping to cover the anatomy section of it and maybe for 5 or 6 talks. But it is going to be a bit detailed, so I'm hoping that there's a lot of takeaway from this. So today's two sections will be the craniovertebral junction and the subaxial cervical spine. So let's dive into it. First is the craniovertebral junction. So we'll start it off with the developmental anatomy of the craniovertebral junction and just what you can identify on radiology. So when it starts out, the atlas has three primary ossification centers. There's one located anteriorly, and there are two located posteriorly. So this is the anterior ossification center. This is the two posterior ossification centers. The anterior ossification center forms the anterior arch, and the posterior ossification centers form the lateral mass as well as the neural arch. In between these are your synchondroses. So these are the joints which have to fuse later on. So between the centrum and the neural arch is something called the neurocentral synchondrosis, the NCS over here. Between both the neural arches on both sides is the intraneural synchondrosis over here. Now this anterior arch and the neurocentral synchondrosis, this will ossify together by 12 years of age. So this is going to take some time. So you're still going to see some defects over here until 12 years of age, and that is normal. But the posterior arch and the interneural synchondrosis, all of it will ossify by 4 to 5 years of age. Okay, so the atlas has three primary ossification centers and no secondary ossification centers, so nothing to worry about there. But remember, the anterior arch will fuse only by 12 years and the posterior arch will fuse by 4 years of age. So as we can see, when it starts out in newborns, there's a wide gap in all the synchondrosis regions, and by 2 years of age this is almost fused, but there's still a wide gap anteriorly. By 3 years of age the fusion process has started posteriorly, but as you can still see, the synchondrosis is not fused here. By 13 years of age everything would have fused, the lateral masses have fused with the anterior arch, and by 12 years of age the entire atlas should have fused. On the other hand, with the axis, it's a little bit more complicated. The axis has 5 primary ossification centers, and there are 4 synchondroses here. Okay, so with the axis, the ossification centers are really not that difficult. There's one for the basal part of the C2 body itself, that is known as the centrum. On the side of the centrum are the neural arches, as normal as any vertebral body would have. The extra ossification centers for the C2, on the other hand, are the apical dense ossification center over here and the basal dense ossification centers, of which there are 2. So there's an apical dense ossification center. There are 2 basal dense ossification centers. There's a centrum ossification centers, and there are 2 neural arch ossification centers. So in between these ossification centers, that is where we'll find our synchondrosis. So between the centrum and the neural arch ossification centers, you have the neurocentral synchondrosis, and between the basal dense ossification centers and the centrum you have the subdental synchondrosis, and between the apical dense ossification center and the basal dense centers you have the apicodental synchondrosis. Right, so just there are 5 ossification centers and there are 4 synchondroses over here. The important thing here is the neurocentral synchondrosis, which is over here, and the subdental synchondrosis. This would have ossified by 9 years of age. So the main part of the C2, or most of it, should have ossified by 9 years of age. So that really leaves the apical dense ossification center. That will ossify a little bit later. There are multiple secondary ossification centers, but one of them is at the dense apex, and that is known as the ossiculum terminale, and that will ossify by 3 to 6 years, but it will fuse with the body only by 12 years of age. So you're still going to see a separate bone, a very small separate bone, until 12 years of age. Right, so this is what is happening at different age groups. As we can see, at 1 month, none of the centers are fused. There's a large amount of space between all the different ossification centers. All the synchondroses are intact. By 6 and 9 months, we're really not expecting massive changes, as that the bones will grow in size. That's about it. By 12 months also, nothing really is going to happen. Fusion should happen at least by 9 years. Right, so as we can see, by 6 years it's here itself. The basal dense centers have fused, and the subdental synchondrosis is gone. That is also fused with the centrum. The centrum and the neural arches are fused onto the side over here, but still the apical dense center is still not fused. This is actually at 10 years. So at 10 years, you can see now the apical dense center has also fused over here. Right. So now moving on from the developmental anatomy, let's look at the anatomy of the bones involved in this, the craniovertebral junction. It starts off with the occiput. The occiput has three important parts involved in the craniovertebral junction. That is the basi-occiput anteriorly, the ex-occipitals laterally. The lateral portion of the foramen magnum are formed by the bones of the occipital region known as the ex-occipitals, and then posteriorly are the supraocciput. So the ex-occipitals are what give rise to the occipital condyles. The occipital condyles should always be more or less oval or round in shape. So they should be convex inferiorly and jutting into the concave C1 lateral mass over here. Sometimes in a normal anatomic change, there can be something known as a synchondrosis intraoccipitalis anterior. That is a small divot at the articular surface on the occipital condyle, and this is normal. This is not a pathology. The atlas is literally the most different vertebra that exists in the entire spinal canal. So it does not have a body. It has two rings, the anterior and the posterior ring. And then in the center of the rings on both sides, you have the lateral masses. The lateral masses give rise to an superior and inferior articular process. On either side of the articular processes, you have the transverse foramina present over here. There's also an anterior tubercle and a posterior tubercle. The anterior tubercle gives attachment to the ALL with the atlas. The posterior tubercle actually gives attachment for the posterior muscles. On either side of the articular processes, you also have something known as a medial tubercle, and this is where the transverse ligament attaches. So you'll be able to see all this anatomy on a CT scan. Sometimes there can be an anatomic variation within the atlas, and the most common one is the ponticulus posticus, that is present in about 15% of the normal individuals. And this area, where this is the C1 arch, and this is the posterior C1 arch over here, and this is the lateral mass of the C1. And as we can see here, this groove where the vertebral artery would run is completely covered by bone, and that is known as the ponticulus posticus. When that occurs, the foramen that it forms through which the vertebral artery passes is known as the arcuate foramen. The axis is also a very different vertebra, but still it is a little bit more like the rest of the vertebra, unlike what is happening with the atlas. So it does have a centrum, but also has this process which sticks out upwards, that is a dens. There is a slight anatomic variation which happens with the C2. There is no lateral mass as such, but you do have a pars. So this, as you can see, this big piece of bone here, that is the centrum. And right from the centrum, you have this pars interarticularis which arises, but the part of the bone between the centrum and the pars interarticularis is what is actually the pedicle of the C2 body. So this part is the pedicle over here. This is the pars interarticularis, this is the pedicle, and this is the vertebral body of the centrum of the C2. The pars interarticularis has a superior facet which is located over here and an inferior facet located all the way down here. Okay, and through the pars interarticularis there's a canal which runs through it, also known as the vertebral artery groove, the vertebral artery cave, canal. There's multiple names for it. The C2 also has an anterior tubercle which is over here, to which the ALL attaches, and then it has the first bifid spinous process. So this is, when you're doing surgery, the most common thing you look for identifying C2 is going to be this bifid spinous process. Right. So let's look at the joints which make up this craniovertebral junction. The C0 C1 complex. C0 refers to the occiput. So as we already saw, the occipital condyles should be convex, while the C1 lateral mass is going to be concave. Right, so the superior articular facet of the atlas is a concave structure. Superior-laterally, whenever you look at these joints, they should slope downwards while coming from lateral to medial. Okay, so the orientation of the joints is such that they are located superior-lateral. On the lateral side, it's more superior, and on the medial side, it's more inferior. With the C1, C2 joint, the primary movement is flexion extension and it limits axial rotation. The C1, C2 joint, on the other hand, is a 4-part joint. Okay, so there's 4 different parts to the C1, C2 joint. There's first of all 2 articulations happening around the dens itself. The articulation between the dens And the C1 anterior arch is one joint. The articulation between the dens and posteriorly with the transverse ligament is actually another joint by itself. Then the two lateral joints, which are the two C1, C2 joints. Okay, so they are a little bit complicated when it comes to surgical anatomy, but radiologic anatomy it's quite straightforward. Most of them are actually horizontally oriented. Okay, and this is the C1 lateral mass. This is the C2 superior facet. This is the vertebral artery groove over here, and right above the vertebral artery groove, this thin piece of bone that you see, this is the pedicle. So whenever you're looking for the size of the pedicle, to identify if a pedicular screw can be placed, this is the sagittal cut you want to go to identify the largest dimension of the vertebral artery groove and look for the size of the pedicle over here. This would be the inferior articular facet of the C2 vertebra. Right. So now that we've discussed the bony anatomy, let's go into a little bit of the soft tissue anatomy. There are a lot of ligaments which take care of this craniovertebral junction, and a lot of them can be identified on MRI now. So we can clearly make out this black structure or this hypointense structure on T1 and T2, or both on T1 and T2, the ligaments will be hypointense. So as we can see over here, this hypointense structure which is covering the anterior surface of the vertebrae is the ALL, or the anterior longitudinal ligament. It is going to attach superiorly at the C1 articular process and run down from there all the way to the sacrum. Similarly, you also have a posterior longitudinal ligament that runs behind the vertebral bodies. It comes up and it forms the tectorial membrane. But in between this anterior longitudinal ligament and the posterior longitudinal ligament of the tectorial membrane, we have multiple other ligaments also. There's an anterior atlanto-occipital membrane that forms between the foramen magnum and the C1. There's an apical ligament which connects a dens to the foramen magnum or the opisthion. There is a cruciate ligament, which is basically the transverse ligament with its ascending and descending leaflets, which will be right behind the C2. You can make out the transverse ligament here, and the best sequence to really make out the integrity of the transverse ligament is the GRE sequence. So this is a GRE sequence where you can make out, this is the transverse ligament over here. The transverse ligament, as we can see, attaches to these medial tubercles on the lateral masses of the C1. So this entire structure is a transverse ligament. This is medial tubercles, and as we can see in this GRE sequence, there's no discontinuity. So this transverse ligament is intact. Right, apart from these anterior ligaments, we also have posterior ligaments. So they have the ligamentum flavum running posteriorly between all the different lamina of the different vertebrae. You also have a posterior atlanto-occipital membrane, as we can make out here. There are also ligaments anteriorly between the dens and the occipital condyle. This is the alar ligament. So as you can see over here in this coronal sequence, connecting the top of the dens to the occipital condyle, these are two alar ligaments. So all of these can now be more or less made out on MRI, and we can evaluate their integrity. The most important one, obviously, is the transverse ligament. Right, now coming to the vessels which supply the craniovertebral junction and what we can make out on imaging. So the most important arteries obviously in the region are the vertebral arteries, and the related segments of the vertebral artery would be the V2, V3 and V4. So I'm sure most of you know this by now, but V1 is a segment from the origin of the vertebral artery to the point where it enters the C6 foramen. Okay, from the point where it enters the C6 foramen all the way up to the C2 foramen is V2. From the point where it exits the from the C2 foramen and winds around C2 C1 joint and enters the exits the C1 foramen, that is the V3 segment. The V3 segment has a vertical part which runs laterally to the C1 C2 joint and a horizontal part which is going to run behind the lateral mass of C1. And the point where it pierces the dura and enters the interdural space is the V4 segment. Right, so these can be identified on CT angiogram. So as we can see over here, this is a C2 body, and this is the transverse foramen of C2. So on this side, you can see it is still inside the transverse foramen. So this is the V2 segment, and this is the part which is coming out of the transverse foramen. So this is the vertical segment of the V3 segment of vertebral artery. This, on the other hand, is a slightly higher cut where you can see the atlas now. So this is the part which is getting out of the C1 transverse foramen and wrapping itself around the C1 lateral mass, running behind the C1 lateral mass in the vertebral artery. So this is the horizontal part of the V3 vertebral artery segment. The point where it will pierce the dura will become the V4 segment. Right, and this is a higher up cut where you can see the V4 segments and they will join together to form the base of our artery. And here, as you can see, intradurally it is giving rise to pica on both sides. Right, a slightly more complicated concept to understand is the different veins in the region. So there's a lot of veins which are present in the region, and we can actually see this on imaging. The clinical significance of this is a little bit questionable, but we'll just discuss what are the different veins which are visible on imaging. So there are some particular venous sinuses which have been named in this region. So there is something known as the suboccipital cavernous sinus. So this is the part of the venous plexus which surrounds the horizontal segment of V3. So as you can see, this part is the V3 horizontal segment exiting the transverse foramen and running behind the C1 lateral mass. This is surrounded here by the suboccipital cavernous sinus. The part of the venous plexus which is surrounding the vertical segment of V3, that is known as the vertebral artery venous plexus. So as you can see over here, this is within the C1 transverse foramen, and this is the vertical segment of V3, and this is surrounded by the venous plexus over here. So that is the vertebral artery venous plexus. So the part surrounding the horizontal part is the suboccipital cavernous sinus. The part surrounding the vertical segment is the vertebral artery venous plexus. Now apart from this, there are multiple other venous plexuses in the region. Marginal sinus is something we'll all be commonly aware of. The marginal sinus is located within the dura at the C0, C1 level, basically at the level of the foramen magnum, and it connects these occipital sinus with all these sinuses which are located inferiorly over here. Apart from that, you also have the suboccipital venous plexus, and this suboccipital venous plexus that we can see over here. 1 second. Yeah, so suboccipital venous plexus here is in the suboccipital triangle, basically outside the entire vertebral canal and the muscle in the region of the muscles, and this will connect to the vertebral artery venous plexus through an anastomotic vein which can sometimes be seen. You also have vertebral venous plexus obviously inside the vertebral canal, and we'll discuss these more in the subaxial cervical spine discussion. But around this region of the CV junction, the suboccipital cavernous sinus, the vertebral artery venous plexus, the marginal sinus within the dura, and the suboccipital venous sinus. These are important. Right, so now coming to the anatomy of the neural structures and within the spinal canal what is present. The things we'll only be able to more or less see with MRI or maybe sometimes CT myelogram. So this, as we can see, is the spinal canal at the level of C1, C2. It tapers from the level of foramen magnum down to C2 as a funnel shape. And the spinal cord occupies about only half the subarachnoid space at C1 level, while the rest of the subaxial spine is going to occupy at least 3/4 of the subarachnoid space. So there's a lot of open free space which should be present at the level of foramen magnum and C1. Right, an important space which is present just above the apex of the dens is known as the apical cave. The apical cave is basically a space which is bounded anteriorly by the anterior atlanto-occipital membrane, posteriorly by the tectorial membrane, inferiorly by the dens, the superior border of the dens, and the alar ligaments, and superiorly by the anterior foramen magnum. Now, normally the contents of this apical cave will just be fat. Okay, so it should be T1 and T2 hyperintense. Now, if this changes, it indicates some or the other pathology. We'll discuss more of that in the subsequent lectures. But important to remember, just above the apex of the dens is an apical cave, which should be T1 and T2 hyperintense because it contains fat. Right, now coming to a discussion of the neural anatomy at this craniovertebral junction. So just a very gentle reminder. Basically, it's an area where your brainstem is turning into the spinal cord, and that is what is known as a cervicomedullary junction. Cervicomedullary junction also is anatomically defined at the point where the corticospinal tract is going to decussate. So we are actually able to identify this point using radiology. So it has been found that the cervicomedullary junction is located about 3.4 with limits of 0.9 millimeters around that. inferior to the inferior margin of olivary bodies. We can also measure it relative to the obex and will be about 6.4 millimeters caudal to the obex. A much easier way to identify that, on the other hand, would be with a CT myelogram. You can identify the superior border of the C1 nerve roots, and that is the point where the cervicomedullary junction should be located. So at the level of the cervicomedullary junction, the spinal cord is going to be more round. As we come down from C3 to T2, the spinal cord is actually more ovoid, and it becomes wider horizontally. That is for the cervical enlargement. The C1 nerve root, as we can make out over here, this can have a highly variable anatomy. The C1 nerve root is usually located just above the atlas. Remember, it has to exit above the C1 arch. It usually might have just ventral roots. Dorsal roots are absent in about 50% of people. C2 nerve roots, on the other hand, have both the ventral and the dorsal roots, and they arise at the C1, C2 level, and they have to exit through the C1, C2 space. Since the dorsal root is present, they obviously should have a dorsal root ganglion. And over here, with CT angiography, you can make out the dorsal root ganglion over here. So in this image with CT angiography, as you can see, the subarachnoid spaces and even the vertebral venous plexus are all appearing hyper dense because of CT angiography, but the dorsal root ganglion will appear hypodense over here. The dorsal root ganglion is also located just behind the C1 C2 joint, okay, and inferior to the C1 lateral mass. And inferior to the C1 arch. So if anybody has assisted any C1 C2 surgeries, you know that this is the location of the C2 dorsal root ganglion, but it can be identified on CT angiography. Right. Another important structure which might be seen at the level of the craniovertebral junction is the spinal roots of the accessory nerve. So this arises all the way from C1 to C5, and it runs behind the denticulate ligaments and ascends upwards to enter the foramen magnum, and they're going to run just behind the vertebral artery. Okay, so this, as you can see, this is the dorsal root, this is the ventral root. It is running between the ventral and dorsal roots, this 11th cranial nerve, but behind the denticulate ligaments. Denticulate ligaments we cannot see on an MRI. Right, and at the point where it is entering the foramen magnum, it runs behind the vertebral artery. So this is the 11th nerve over here, while this is the vertebral artery, which can be made out. Right, so that is about the anatomy of the craniovertebral junction. So we'll discuss a very, very important and well-known topic when it comes to craniovertebral junction anatomy imaging. That is measurements. How do we make out there is a problem at the craniovertebral junction? So there are a lot of different measurements, and we just need to know a few of them. So first of all, how do we measure if there is skull base flattening, basically known as platybasia, which might be associated with craniocervical kyphosis, basically a significant bend which is happening here, which might indent the brainstem, or might be associated with basilar invagination. All concepts we have discussed previously with craniovertebral junction lectures, but just a reminder of how to do these measurements. Right? So the Welcher basal angle that was described was first described actually for X-rays. So this was done through a line which extended from the nasion to the tuberculum sella, and another line which extended from the tuberculum sella to the basion. Now that was done on plain X-rays. With MRI, it is a little bit more difficult to actually measure this angle using these measurements. So that is why, for the purpose of MRI, this has been modified to a line which runs along the ACF base and a line which runs along the posterior border of the clivus. The values are mentioned here. Okay, so no need to memorize them. You can just always look them up for reference. Other important angles which can point out craniocervical kyphosis is known as the clivus canal angle. So this angle is measured along the Wackenheim clivus baseline, which is over here, and the angle formed between this line and a line which is running along the posterior border of C2. So in flexion, this line can be up to 150 degrees. This angle can be 150 degrees. In extension, it might increase to 180 degrees. A line with this Wackenheim clivus baseline running along the posterior border of the clivus can also obviously be used to measure basilar invagination. And normally the dens should be completely below this line. But apart from the Wackenheim-Clival line, there are also multiple other ways to measure BI. The most well-known ones being the Meckrae's line. And the Meckrae's line is drawn from the basion over here to the opisthion, right? So opisthion is literally the most pointed area of the posterior border of the foramen magnum over here. So you go into the midline, identify the lowermost portion of the clivus and the most pointed area of the posterior border of the foramen magnum. Join these two, the dens should definitely lie completely below this line, right? But there are times when you're not able to see these. Especially on X-rays, you might not be able to see the basion and opisthion, and you might just be able to see the hard palate. All right, so then you can use other lines like the Chamberlain's line or the McGregor's line. So Chamberlain's line exists from the hard palate to the opisthion, but at times you're not able to see the opisthion. So you can instead take a line to the lowest point of the occipital bone, so that at least you might be able to see properly, right? So the measurements are given over here. As you can make out, the measurements are not the same for films, for X-ray films and for CT. So that has to be kept in mind. Another way to define basilar invagination could be using Clark stations. So the dens is divided into three different stations, first, second, and third. And the C1 arch should be, that is basically the first upper 1/3, middle 1/3, and low 1/3 of the dens. And the C1 should be lying within the first station. If it is lying at the level of the second or the third station, it is also considered as basilar invagination. Now there are times when you're not able to visualize the tip of the dens and you cannot make out if basilar invagination exists or not. So for those times you can use other measurements like the Redland-Journal criteria or the Ranawat criterion. So the Redland-Journal criteria again uses the McGregor's line. So a line drawn from the hard palate to the lowest point of the occiput over here, and then a perpendicular drop to the inferior border of the C2. So measurements are mentioned here, so it can be also used to evaluate for basilar invagination. Apart from that, there's also the Ranawat criterion, which can be used to measure the same basilar invagination. You take a line along the transverse axis of the C1 and drop a perpendicular connecting it to the center of the C2 pedicle. Right, so this distance is the Ranawat criterion, and again, the values are mentioned here. Right. So there are some measurements which can be done to also evaluate C0, C1 dissociation, or basically atlanto-occipital dissociation. A very rare entity to find because most of the patients who have a traumatic atlanto-occipital dislocation are going to be dead at the time they've had it. Right. So some of the if a patient with this does make it to your clinic somehow, then you can use these values to identify this dissociation. One is known as the basion to dens interval. So this is the interval from the tip of the dens to the basion. Okay. Another is the basion axial interval. So that is from the basion to a line drawn along the posterior border of C2. So these both should technically be usually less than 12 millimeters. There's also now something known as the power ratio. The power ratio is is basically the measurement of two lines. One is between the basion and the C1 neural arch, and the second line is between the anterior atlantal arch and the opisthion. So this measurement should be equal. If it is not, it indicates again C0, C1 dissociation. Another thing which can be done is basically measure the distance between the occipital condyle and the C1 right in the middle of the joint, and sum both of them on both sides, right and left. If it is less than 4.2, it is normal. More than that, it indicates C0, C1 dissociation. On the other hand, C1, C2 dissociation, most of us would know how to measure this, right? So the most important variable here would be the anterior atlantal dental interval. So the anterior atlantal dental interval for adults should be less than 3 millimeters, and for children can be up to 5 millimeters. But as you can make out over here, that is in plain films. That is something that most of us are mostly not aware of. These values are for plain films. For CT, the values are actually less than 2.6 millimeter for children and less than 2 millimeters for adults. Right? And another thing is that actually the anterior atlantal dental interval should be measured at the lower border of C1 and not in the center. Right? So just something new to learn here, that for CT, the values are different. Because all of these values are actually defined using X-ray images. And so now what has been found with CT and MRI is a significantly different value. The posterior atlantodental interval basically measures how much space is there in the spinal canal. So that is also important for C1, C2 dissociation. You can also measure the C1, C2 spinolaminar line over here along the anterior border of the spinolaminar junction. And something known as the atlantoaxial interval. Okay, so that is the measurements between the occipital condyle and C1. Right? So this is measured at three different areas, medial, lateral, and the middle segment, and joined together. So it gives you the total interval. It should be less than 3.9 for children and less than 3.4 for adults on CT. Right. So let's get into a few questions. You can leave the answers in the chat box. There are no options for these questions because I think most of these are fairly obvious answers. Can you identify what is this structure? So you can put down the answers in the chat box. Yeah, so this is the arcuate foramen. So as we have discussed, sometimes it is possible that the vertebral artery groove can be covered by a segment of bone, which is known as the ponticulus posticus. So this would be the ponticulus posticus, and the foramen which is running, through which the vertebral artery is running, is known as the arcuate foramen. Right. So can you identify this anomaly? In a patient who is 16 years old. Okay, so we can see this discontinuity between the apical segment of the dens and the basal segment of the dens. Okay, so this is an os odontoideum. On the other hand, what is this anomaly? Okay, so this is an ossiculum terminale. Okay, so just very clear how to make out the difference between these two. When there's a significant part of the dens which is separate from the rest of the C2 body, you should think of an ossodontoideum, right? So that is, it's basically, the problem here lies that the dens has not fused with the C2 body. Sometimes there might be a small stump of the dens which might stick out of the C2 body, but a majority of the dens has not fused with the C2 body. On the other hand, when only the apical segment has not fused, that is when it is an ossiculum terminale. Ossiculum terminals are generally not associated with instability because there's a significant portion of the C2 which can be kept in place by the transverse ligament. On the other hand, because this part is separated from the rest of the C2, and this is usually where the transverse ligament will come. So that is why there is instability in ossodontoideum. Right. Now let's discuss the radiologic anatomy of the subaxial cervical spine. So subaxial cervical spine more or less is similar to the osteology and the developmental anatomy of the rest of the spine, but also it is quite different from what we have discussed for C1 and C2. There are again three primary ossification centers, one for the centrum and two neural arches. The neural arches are what is going to give rise to the lamina, to the spinous process, to the transverse processes over here, and the foramen transversarium. Between the centrum and the neural arches, you have this gap, which is the neurocentral synchondrosis. And between the two neural arches on both sides, you have the interneural synchondrosis. Now, the neural arches will fuse posteriorly around 2 years of age. That is quite early. And then they will fuse anteriorly around 3 to 4 years of age. So as you can see, as compared to C1, C2, the subaxial spine fuses a lot earlier. The fusion should be more or less over by 4 years of age. So as we can make out over here, in this newborn, nothing is yet fused. But by 2 years, as we can make out, the more or less the entire entire vertebra has fused. Right, so the same thing, by 5 years, the entire primary ossification centers of all of the entire vertebra has fused. Right, so now let's discuss the osteology of the subaxial cervical spine, basically from C3 up till C7. When it comes to these vertebrae, the vertebrae are designed in such a way that the transverse axis is longer than the AP axis. The anterior and the posterior height of the vertebrae is going to be similar. This is unlike what we see in the lumbar spine. In the lumbar spine, the anterior height is going to be longer than the posterior height, and that is to maintain lordosis. This lordosis, on the other hand, in the cervical spine is maintained by the intervertebral discs and not by the height of the vertebrae itself. So here, the anterior and posterior heights are similar. On the other hand, the AP length of the inferior end plate here is going to be much longer than the AP length of the superior end plate of the caudal vertebra. Apart from just the basic design, which has the body, the spinous process, the lamina and the pedicle, you also have some other structures which are present only in the cervical spine. The important one being the uncinate process over here. So this exists from C3 up till C7. Rarely it might be found in T1 and T2 also. So these arise from the superior end plates and they connect to something known as echancroris on the superior vertebra over here. So there will be a small depression on the inferior end plate of the cranial vertebra, and that is where the uncinate process joins to form the uncovertebral or the Luschka joints. Now these joints help to limit a lateral rotation and also help to stabilize this entire spine. So this is the part of the echancroris on the inferior end plate, and this is the uncinate process on the superior end plate. Apart from that, you also have the transverse process. So this can help you easily identify that this is a cervical vertebra. If you just look at how this transverse process anatomy is arranged. So this, as we can make out, is the vertebral body or the centrum. You have the obvious spinous process and the lamina over here. And then, so the centrum of the body is going to connect with the lamina through the pedicle. So this is the basic anatomy of any vertebra. Now the differences arise with where does the transverse process and the lateral mass lie. So when it comes to the cervical vertebra, the transverse process is this one. So this arises basically at the junction of the body and the pedicle. And just from the lateral aspect of the pedicle, you have the lateral mass of the cervical subaxial spine. Right. The transverse process, as we discussed, is going to arise from the lateral part of the vertebral body where it joins with the pedicle. The transverse process, just in front of the transverse process, you have the foramen transversarium through which the vertebral artery is going to run. The foramen is covered anteriorly by an anterior bar, and that is known as a costal process. This is basically analogous to the rib process of the thoracic vertebra. Now this has an anterior tubercle, and the anterior tubercle will increase in size from C3 to C6. The anterior tubercle at C6 is also known as the carotid tubercle of Chassenach. So as we can make out, this foramen transversarium Medially is formed by the pedicle. Anteriorly is formed by the anterior bar of the costal process. Posteriorly is formed by the transverse process, and laterally over here you have a costotransverse bar. Right, so we've discussed the costotransverse bar. So again, in this image, as you can make out, this is the intervertebral foramen over here. Anteriorly, here we have the uncovertebral joints. Posteriorly, we have the facet joints, also known as zygoapophyseal joints. This is the transverse process with the transverse foramen. So the posterior bar is the transverse process, the anterior bar is the costal process. There's an anterior tubercle over here, and there's a posterior tubercle over here. Right, so apart from this, you also have the pedicle, which arises just inferior to the uncinate process, runs posteriorly and joins with the lamina. And from the lateral aspect of the pedicle and the laminar junction arises the pars interarticularis. Now the pars interarticularis will arise at the junction of pedicle and lamina and will have a superior articular process and an inferior articular process. Apart from that, you also have posteriorly the lamina and the spine. The spinous processes of C3 to C6, as we can make out over here, are bifid, while the spinous process of C7 is going to be monofid, but it is quite long. Right, so apart from that, on imaging, we'll be able to see the neural foramen, and this actually is a very important structure to identify on imaging, because this is where we want to look for when we are identifying nerve root compression. So the neural foramen is formed anteriorly, as we discussed, by the uncovertebral joints, posteriorly by the facet of the zygoapophyseal joints, superiorly by this notched aspect of the pedicle. This is known as superior notch, superior vertebral notch, and there's an inferior vertebral notch over here, again in the inferior pedicle, and these are the superior, inferior, anterior, and posterior boundaries of the neural foramen. The floor of the neural foramen is usually formed by the pedicles medially, but this costotransverse process laterally. So as you can make out in this MRI over here, okay, so this here would be your uncovertebral joint, this is the facet joint, and this is the neural foramen. Okay, so as this will be the spinal nerve. All this hyper intensity surrounding it is not CSF, it is fat. This bone, since it is quite lateral, is not the pedicle, it is actually the costotransverse bar. Okay. Now the intervertebral disc at the subaxial spine, remember we have not discussed these at C1, C2 because there are no intervertebral discs at C1, C2. But in the subaxial spine, they're obviously present. Now the thing with these discs are that the ventral height, the height anteriorly is more than the height posteriorly, and that is how lordosis of the cervical spine is maintained. Usually the anterior annulus is going to be a lot thicker than the posterior annulus. So as you can see, this hypointensity is a lot more than here posteriorly, and that is why the anterior annulus is a lot thicker and the posterior annulus is a lot thinner. As we age, the nucleus pulposus becomes less and less obvious. So by 30 years of age, actually with cervical spine, the nucleus pulposus and annulus fibrosus cannot be differentiated anymore. So as you can see in this patient in this normal spine at 40 years, the intervertebral disc is more or less homogeneously T2. You cannot make out the difference between nucleus pulposus and annulus fibrosus after 30 years of age, but this is not indicative of a significant pathology. Okay, so apart from that, another area of anatomy which is important is the facet joints. So as we know, the pars interarticularis is going to arise at the lateral surface of the part where the pedicle joins with the lamina, and the pars interarticularis has a superior facet over here and an inferior facet over here. The superior facet obviously points superiorly, but also is going to face posteriorly. The inferior facet faces anteriorly and inferiorly. Now, whenever you're looking at axial images, always remember that whatever cut you take at any point, the inferior the superior articular process of the inferior vertebra will always be anterior to the inferior articular process of superior vertebra. So whenever you're looking at these axial cuts, just remember that the process in the anterior aspect is going to be the superior articular process of the inferior vertebra, while the process posteriorly is going to be the inferior articular process of the superior vertebra. Now, this angle of inclination of these joints will be more or less horizontal at the C3, C4 level, and as you go down, the angle of inclination increases. Okay, so there are a lot lesser ligaments at the level of the subaxial spine as compared to C1, C2. The important ones, again, we have the anterior longitudinal ligament, this hypointense structure as we can see over here. There's another long hypointense structure posteriorly behind the vertebral bodies, that is the posterior longitudinal ligament. These are the important ligaments anteriorly. The anterior longitudinal ligament helps to prevent hyperextension, while the posterior longitudinal ligament helps to prevent hyperflexion. We also have the ligamentum flavum over here, running between the laminae of adjacent vertebrae. Apart from that, another important structure you can identify in the cervical spine is the ligamentum nuchae. Okay, so it's over here. This ligamentum nuchae basically runs, there are two components to it. There's a funicular component and there's a lamellar component. The funicular component is a stronger component to which all the muscles attach, and this runs directly from C6 or C7 spinous process all the way to the external occipital protuberance. So this is the hypointense structure which you can see over here. Sometimes in children who are aged 1 to 8 years of age, because of ligamentous laxity and multiple other reasons, there can be something known as pseudosubluxation, which we should not take as a pathological entity. So this subluxation usually happens at C2, C3 level in 10 to 20% of children who are aged 1 to 8 years. But sometimes, rarely, it can happen at C3, C4 level also. Now this can happen because these facet joints are a little bit more horizontal as compared to the lower down facet joints. In children, you have a lot more ligamentous laxity. Sometimes the uncovertebral joints are supposed to stabilize the spine are not very well developed. In children, the neck flexion happens at a slightly higher level than at the lower levels. So because of that, they can develop the pseudo-subluxation, and the skull is relatively large as compared to the rest of the body. So that's another reason. So one way you can identify whether this subluxation is actually pathological or not is using something known as a Swiss chuck line. So this is drawn from the anterior border of the posterior neural arches over here between C1 and C3. Right? So if the anterior border of the C2 neural arch over here lies 2 millimeters or more anterior to this line. Okay, so up till 2 millimeters is okay, but if it lies more than 2 millimeters anterior, then it is pathologic, right? So you basically have to draw a line. This is the neural arch. So here, till the neural arch of C3, okay, and then just see that where the anterior border of the C2 neural arch is going to cross this line. If it is less than 2 millimeters anterior to it, it is okay. But if it is more than that, it indicates that it's a pathologic subluxation for that child. Okay, so apart from the vertebral arteries, when it comes to cervical spine, there are other important arteries also. But again, the most important one is the vertebral artery. So here the important segment will be the V2 segment. Apart from that, segmental arteries to this region are provided by ascending cervical, deep cervical, and the costocervical trunk. The vertebral artery is going to enter the C6 foramen in almost 90% of human beings. It can enter the C7 foramen in 6% and the C5 foramen in 4%, and at other levels in very, very rare cases. Usually the left vertebral artery is dominant, but there's a lot of variability which can happen. Sometimes either of the vertebral arteries may be hyperplastic. So in this case, as you can make out over here, the left vertebral artery is hyperplastic. An important concept that sometimes you might hear is that the larger the transverse foramen, the more likely that vertebral artery is dominant, but it doesn't necessarily correlate. As we can see over here, this foramen is larger, but this vertebral artery is smaller. So it doesn't always correlate, and it is best not to use that idea. Apart from that, the vertebral artery can actually be quite highly tortuous even while running between this bony canal. It can impinge onto the body of the vertebrae or sometimes into the neural foramen also and cause problems. Right, so the venous anatomy is again slightly a bit more complicated than the arterial anatomy, but it might be slightly helpful to know what are the different contrast enhancing structures we see on contrast MRIs. So when it comes to the venous anatomy of the cervical spine, there's an intrinsic system, an extrinsic system, and an extradural system. The basic idea is within the spinal cord, you have the intrinsic system. Outside the spinal cord, but within the dura, you have the extrinsic system. And then you have a system which is outside the dura, known as the extradural system. So the veins within the spinal cord form an intrinsic system, and they drain then into the extrinsic system. The extrinsic system basically has a coronal plexus, which is around the spinal cord itself. So there will be one vasocorona of veins, which is all around the spinal cord. And that will drain further into anterior and posterior radiculomedullary veins, which will get out and finally drain into this extradural system. The extradural system is slightly more complicated. There's an internal system here, and there's an external system here. The internal system basically again is going to be located within the spinal canal, but outside the dura. Right? So here, this contrast enhancing structure that you're seeing all around is the internal extradural system. Right? So you have an anterior and then you have a posterior internal vertebral venous plexus. There is also an external system which is outside the vertebral bodies. So you have an anterior external system and there's a posterior external system. Now, most of these are connected by valvulus veins. So there's a lot of retrograde venous drainage which can happen through any of these systems. Right. Apart from that, there's also another important concept we'd like to discuss, that is, what are the different spaces within the cervical canal? So you obviously have the epidural space, which is actually a real space when it comes to the spine itself, unlike with the cranium. There's also a potential subdural space which exists. Now, this subdural space and the subarachnoid space can be difficult to differentiate, and whenever we do a contrast myelogram, contrast usually accumulates in the subdural space because it is given through an LP. So subdural or subarachnoid space, which can be difficult to differentiate. But some contrast, because there is venous flow happening elsewhere also, can also accumulate within the epidural space. So whenever you do a contrast myelogram, as you can see, this much more hyper dense white line which is over here is the subdural space. But on the outside of that, there's also some area where there's lesser amount of contrast, right? So that is the epidural space. So both these spaces are present in the spinal cord, and we can differentiate them using this particular technique by identifying which area it is located in and how much contrast is accumulated. Right, so now coming to the neural anatomy of the subaxial cervical spine. The spinal cord, as we've discussed already, is going to be more circular at C1, C2, and as we come down, it becomes more ovoid because from C3 to T2, you have this cervical enlargement which happens. There are structures you can identify within the cervical spine. So there's a ventral median fissure, there's a dorsal median sulcus which can be seen. There is also the dorsolateral sulcus, and that is the root entry zone of the dorsal nerve root. There's also a ventrolateral sulcus, which is the root entry zone of the ventral nerve root. So this can be seen on a CT or an MR myelogram. Apart from that, with a high resolution MRI, you might be able to see some white and gray matter organization also. So as we can make out over here, there is white matter on the outside and there is some gray matter on the inside. Not very clear, but so the important areas you might just want to differentiate. Sometimes you might be able to see a T2 hyperintensity or some contrast enhancement happening in particular regions. Is to know there is a dorsal funiculus, here. There's a lateral funiculus and there's an anterior or ventral funiculus. Okay, and there's a gray matter located in the center over here. Obviously, tracts cannot be made out in the spinal cord. With DTI and tractography, there are some large tracts which can be made out, but more or less tracts cannot be made out in the spinal cord. It is just important to know what tracts might lie in different regions of the spinal cord. So dorsal column is obviously made up of the dorsal column tracts, or basically the fasciculus gracilis and fasciculus cuneatus. Laterally is where your corticospinal tract is going to lie, and anteriorly there are a lot of descending tracts, such as the reticulospinal, the vestibulospinal, and the anterior corticospinal tracts. But these we cannot make out on radiology. Right. So apart from the tracts running within the spinal cord also gives rise to nerve roots. The nerve roots arise from both ventral and dorsal rootlets, and they join together at the level of the intervertebral foramen over here. Okay, and run out. And here is where you're going to also encounter the dorsal root ganglion. The dorsal root ganglion at these levels lacks a blood-nerve barrier, and that is why at these levels it's going to enhance avidly on contrast. Right. So when it comes to the cervical spine, the nerve roots arise one level higher than at the point they're going to exit. As you come lower down at C7, C8 level, they're going to be going out more in a more angulated fashion, but slightly at C3, C4, it runs out slightly more horizontally, but at least one level down. So that is how to calculate the spinal level as with correspondence to the vertebral level. For cervical spine, it is 1 plus 1. Okay, so that is about the discussion of the anatomy of the cervical spine. So we'll just go through a few questions. These might be slightly more difficult, so because we have not discussed them during the seminar, but I'm hoping we'll be able to get these. So can we identify the following structure over here? Okay, but we'll also go through what are the rest of the structures we can see. You can leave the answers in the chat box. So this over here is the pars interarticularis with the inferior articular process, the C3 pars interarticularis with the superior articular process, and this is the facet joint. So you can see its angulation over here. This angulation becomes important when we're trying to place a screw intraoperatively. This is the zygoepiphyseal or the facet joint. Okay, then this area would be the lamina, this box, and this is the spinous process. Okay, so this, as mentioned correctly, is the spinolaminar junction. Okay, so can we identify this structure? Okay, so this is the intervertebral foramen, and what we're asking is what is the superior boundary of the intervertebral foramen or the neural foramen. Okay, so this is the pedicle over here. This is the pars, but where the arrow is pointing is the pedicle. Okay, can we identify what is this structure? Okay, so just a overview of what all the different structures here. This is the C1. Behind C1, running above the C1 arch, is the vertebral artery horizontal segment of V3. Here, this would be the C2 nerve root. Okay, here is again the vertebral artery running through C2. These are the different neural foramina. And as we know, the inferior border of the neural foramen is formed by something known as the costotransverse bar. So that is what this is. This is the costotransverse bar. Okay. This here, this hypo-intense structure over here is what is the nerve root. And the entire thing which is hyper-intense around it is fat.